starting as a first webinar in hand as PIP joint injury. So Parag Lad is the convener for this, and Dr. Hemant Patankar is the chair. So over to Dr. Hemant Patankar. Sir, you can take over.
Thank you, Dheeraj and Sandeep. I welcome you all for this webinar series organized by the BOS. It's a very good idea, according to me. And the first webinar of this kind is on the PIP joint injuries, and it is titled as PIP joint injuries unlimited. We plan and hope to cover most of the problems involving the PIP joint injuries. And I've got a very competent convener with me, Dr. Parag Lad, and he will run us through the next speakers. And we plan to cover most of the topics, and we will end up with question answer sessions after each speaker, if time permits. RNs will have a general round of questions at the end of the webinar. Parag, can you introduce the first speaker and request him to share his screen?
Yes, sir. Thank you so much, sir. I invite Dr. Pankaj Ahire, Senior Hand Surgeon from Mumbai. He is going to speak upon understanding PIP joint biomechanics. Over to Dr. Pankaj Ahire. Dr. Pankaj, I am not hearing your voice.
So am I.
Yeah.
Please unmute, sir. Pankaj, sir.
Yeah. Yeah. Oh, but I said all the important things already. Okay. So PIP joint poses challenge to not only the untrained hand surgeon, but also to trained hand surgeons. And there's a reason why this joint is so peculiar as compared to the rest of the joints in the hand. I would say in terms of the mechanics, it is a very, very unique joint, and I'll take you through why. This is your PIP joint, and this is a wonderful slide which was prepared almost more than 100 years ago and published in first ever textbook written for hand surgery by Canneville. It shows all the important structures that you need to know about in a PIP joint. So if I were to schematically convert this into a schematic drawing, this is how it would look. And just for simplicity, P1 is what we call proximal phalanx. P2 is middle phalanx. There is a volar plate that is attached to the base of P2 on the volar side. There's a FDS tendon attached quite far away from the volar lip. And then there's a central slip which is attached right on top of the dorsal lip. This is the scheme of things that makes the PIP joint. And of course, we have a ACL and a PCL in PIP. ACL stands for accessory collateral ligament, and PCL stands for proper collateral ligament. And we will see how each of these structures plays a role in PIP joint mechanics. So there are four broad structures which we need to understand. One, the bony structures, the P1 and the P2. Then you have tendons, the central slip. Then just give me a moment, please, because this is blocking my, yeah, this is good. Yeah. So tendons, the central slip and the FDS. Then the volar plate, which is quite an important structure, especially in the injuries that we're going to see. And of course, the ligament, the ACL and the PCL of the PIP joint. So let's look at the role of P1 and P2. If you see the radius of curvature of the P1 condyle, okay, and you see the radius of curvature of the P2 condyle, the one which is marked in red and yellow. The P2 condyle has a much larger radius, and in doing so, as this joint flexes, the center of rotation is not fixed. And because this tends to be a little more flat, there is an inherent tendency for the joint to translate as it tends to subluxate. And it is the role of the external stabilizing structures to make sure that there is no translation and the joint continues to glide. A good PIP joint is the one which glides, whether injured or not injured. The moment it translates or hinges, you start getting problem and it could lead to late arthrosis. And the whole purpose of treating PIP joint injury is to ensure that we get a gliding joint. So in doing so, to maintain the joint congruous while it is tending to translate because of the difference in the radius, the external structures play a very important role, and we will see how they play an important role. So let's look at the central slip and the FDS, and of course FDP. I will also towards the end tell you what role FDP has in stabilization of the PIP joint. So this, we come back to our diagram like this, and if you see the attachment of the central slip and the FDS, you will realize these are the only two dynamic structures here. Rest are all static stabilizers. The collateral ligaments, the volar plate, or the bony architecture are static. These are the dynamic ones. And because of their difference in the attachment, as they as they act on the PIP joint, they create a torque which is centered somewhere in the base of the P2. Because of this torque, there's a constant tendency for the joint to subluxate dorsally, which is negated by the collateral ligaments and the volar plate. So if this volar plate were to lose that control over base of P2, if like this is the commonest fracture pattern that we see, then this same force couple is now going to cause a dislocation. Logically, the treatment involves getting this piece back to where it belongs. And my subsequent speakers will tell you various ways of how to put this piece back. It could range from a simple close reduction to an extensive fixation to a kind of arthroplasty, and they will take us through everything. Now, the role of volar plate. If you see, as the finger flexes in the beginning, the volar plate tends to simply gets pulled. Okay, this is required to negate the translation that we were talking about, and this is effected through A3 pulley. Normally, we say A3 pulley is not important, but A3 pulley through the flexor tendons gliding through it affects this. Now, the next stage in the finger flexion is when the finger is a little bit flexed, and now the tendon through A3 pulley attachment lifts off the volar plate of the bone, thereby creating this recess where my arrow is. And in that recess, this finger is going to glide. This is where the role of FDP also comes in. Dr. Patankar, I'm sure, will mention in his talk about the role of early FDP mobilization. And sir, I do very strongly feel this is one of the mechanisms by which FDP helps the PIP joint. Then comes, just a moment, please. Okay. Then come the role of ACL and PCL. So again, the same injury that we talked about some time ago. Now we have superimposed the ligaments. When there is a small volar lip fracture, typically less than 30% of base of P2, the accessory collateral ligament and the volar plate and this volar lip form one unit, whereas the collateral ligament proper remains attached to the base of P2. In such a situation, when this joint is reduced, it creates a very stable situation, and seldom you require any fixation. Just making sure that the collateral ligament proper is made tight in this position will ensure good healing. And the biomechanical studies prove that as we start flexing the PIP joint, the collateral ligament becomes tighter and tighter, almost increases in length by almost 2.6 millimeters. And in doing so, it allows for a congruent joint and does not allow the joint to translate. Whereas if you take another situation where the volar lip is almost the volar lip is almost 50% of the base of P2. In that, now the ACL, PCL, the volar lip, and volar plate are all one unit. And the only thing that is attached to the middle phalanx now is the force couple of extensor tendon and the FDS. This is a potentially very unstable situation. No matter how often you reduce it, it will keep dislocating. And the only way to maintain this reduction would be to achieve some kind of a fixation. So the size of the volar fragment matters because it determines where your collateral ligament proper is going to go. So just a clinical example. So if this is a volar lip fracture, as you can see, the volar lip is only about 30 to 40% gone. Therefore, as we reduce this joint, the collateral ligament will act as a stabilizer, and all you need is get the P2 to flex so that this fracture reduces, and then you maintain it in flexion by whichever means. So these are the type of fractures which will go in for close reduction. Another scenario where there's a much larger chunk of the volar lip, if you just look at the base of P2, this is almost 40 to 50%, and here the collateral ligament is attached to P1, and it would require some kind of fixation. This is just one representation. You may either require some kind of a fixation like this, or some kind of a fixation like this. So from here, I would hand it over to my next speakers to take you through a variety of PIP joint injuries and their management. Thank you.
Thank you, Dr. Pankaj, for nice illustration. And now I invite Dr. Rohan Habu to speak upon acute injuries and how to deal with them. Over to Dr. Rohan.
You can hear me, Parag?
Yes, very well.
Okay. Hi, good evening, everyone. My topic would be management of acute volar lip fracture dislocations, navigating the treatment with wires and fixators. Like Pankaj described earlier, there are different aspects of or different types of volar lip fractures, and each kind of decides whether the joint needs a fixation or close reduction or doing nothing. I think the biomechanics were quite clear. The larger the piece that you have on the volar aspect, probably more unstable the fracture is, and maybe you end up needing a bit more than just wires. That's the kind of schematic that most of the books will tell. The differentiation would be 30%, 40%. It keeps changing between the numbers, but all said and done, whenever you see an acute volar lip fracture dislocation, you need to reduce it well. You can do it with a gentle traction in line with the deformity. You gently translate the middle phalanx over the head of the proximal phalanx and gently flex it. Assess this for stability in the range of movement. So the patient should be able to get 30 to 90. And you assess how much flexion the patient gets. Now, if you get these two in place, the range and the end of flexion with minimal pain, most of the times the joint is stable and you may end up doing something just with the wires. Otherwise, we decide that this is an unstable and you end up doing a bit more, which
join the meeting.
Which my other colleagues would describe. Now, varieties of things that you can use to stabilize this fracture dislocation. The simplest thing would be simple tapes. You can use a splint and a plaster. And my topic would be dorsal block wires or fixators. Briefly about taping. If you have a simple fracture or you have a stable fracture, you can actually put a tape. We've tried this.
Has joined the meeting.
We've tried this by taping in complete flexion of 90 degrees, but you can't exceed more than a week because there is a risk of stiffness. You can start supervised mobilization. Here the patient is moving from about 30 to 90. This is at about within the first week. And at 1 week, you switch them to simple dorsal block splints and start mobilizing them.
Has left
The issue
meeting.
with this could be the risk of stiffness. And right in the beginning, if there is a lot of edema, there could be a vascular compromise.
Secretary boss has left the meeting.
The other aspect of treating these injuries would be blocking it with a splint at about 30-degree flexion. You can use these lumofoam splints, or you can also use plasters for this. So these are quite handy, inexpensive, and do allow you some range if you don't feel the need of fixing these fractures. However, they do have some side effects or issues. They could lead to stiffness if you don't mobilize them early. And it's very difficult to use these two treatments, the tapes and the splints, if you have an unstable fracture pattern or if the finger itself is quite stubby and edematous. The patient may be non-compliant with the splint or may end up having some skin irritation. So these would be the indications to use wires for acute volar lip fractures and dislocations of the PIP joint. Please ignore the bottom picture. This is something that we should not be doing. You see a big round piece here and you feel that, okay, let's put a wire through and through from the volar aspect into the dorsal side. But always remember that there are two big tendons that flex the finger in this side. So this area is a no-no area. This fixation could be good enough for a dorsal piece, but never for a volar piece. So primarily the wires in my practice would be the use as a dorsal block. The way the splint blocks the extension, I would use them as a dorsal block. The good thing about this is it's a fairly minimally invasive procedure. It can be done in a fairly short bit of time, and you can start early mobilization on the day of surgery. The downsides would be management of pin track issues. If not moved early, could end up getting a flexion contracture. And very rarely, you might end up having the wire that is backing out. The angle at which the wire is passed at the joint is decided when you do a close reduction and you assess at what extension point the joint is dislocating. If it's say about at 30 degrees, then you can pin the joint or block the joint at 30 degrees flexion in this way. This is done with a digital block. We can use a 1.2 or a 1.5 millimeter K wire. Like I said, you need to decide the angle at which you want to block the extension. So in this, it was about 30 degrees. So we marked it on the C-arm. You can see a congruent joint. But when you actually want to pass the wire through into the middle phalanx, you ensure that the middle phalanx is completely flexed, and then you drive the wire in. This allows you a freedom of extension and flexion from 30 to 90 degrees. Some examples. So this was about, this was an early presentation at about day 2, day 3. About 25% or 30% of the surface involved. We were able to close reduce it and pass a dorsal block pin. Despite having a big fragment here, it actually heals very well because it is a close reduction. Similarly, another piece, about 25% on the volar aspect. And this is, I think, at about 2-month or a 3-month mark. It is this finger. You can still see there's a little bit of stiffness, but they end up doing quite well. Sometimes if you don't have much options, you can use it for a slightly larger fragments, but I would not recommend this because they end up having a significant bit of stiffness. If you're adept at moving them early, supervised movement, then you may try this. You can see this is a large involvement of the base of the middle phalanx, but we ended up getting a fair bit of extension at about 30 degrees and flexion of the joint. Now, very rarely, this was done, I think, in a patient which probably has, who probably has some issues of the skin where you may not be able to do an open reduction. But again, this is a rare thing. Always remember, if you're fixing this or blocking it, you should start moving as early as possible so that you end up having a good congruent or remodeling of an irregular joint surface. The other use of wires in PIP joint injuries would be used as fixators. However, my experience of using fixators in acute volar lip fractures is quite less. We primarily use this when there is an open fracture of the PIP joint. Just use wires and then stabilize it at a a stable position or a reduced position till the wound heals, and then maybe end up doing a permanent or a definitive procedure. I've not used a Suzuki frame for an acute injury. I'm sure some of my colleagues ahead would discuss this for a different indication. So in summary, wires primarily prevent a dorsal displacement of an acute volar lip fracture dislocation. It has its own pros and cons. However, if you are able to manage the patients, follow up the patients well, encourage them to move with the wire in, you end up getting a decent range of movement. Most of the literature says about 80 to 90 degrees range of movement. However, if you have an unstable pattern, despite putting a wire in, you abandon the procedure and you end up doing something definitive. Thank you.
Thank you. Thank you, Rohan. Any questions from the faculty? We finished in time. So, Rohan, I just want to know, for the benefit of everybody in the audience, that you decide putting a splint versus dorsal block wire based on the fragment size or based on your reduction? Or you check them under CM?
So this is primarily acute injuries where you have not yet taken the patient on table. So you do
Yes.
it in an emergency and you see how good a reduction is. If it's a sausage like finger, splint is definitely, so I would definitely I would counsel them for a dorsal block pin.
Okay.
However, if you see them on day one and you're lucky enough to put them back on day one, then the splints do work because the edema is not yet set in.
Okay. Okay. Thanks, Rohan. I would like to share my screen now, and I thank WIROC current organizing team for this opportunity. And my topic here is subacute PIP joint fracture dislocation and how to regain the function by salvaging our bone and soft tissues. I hope my screen is visible and I am audible. Am I audible? Hello?
Yes, yes, yes.
Yeah, okay. So this is the okay. So here the concern is always what is acute and what is subacute. According to me, 8 days to 21 days duration, we label it as a subacute injuries. And the point here is, will the conventional method, as Dr. Rohan mentioned about the splint and wire, will work, or we need to consider something else at this point of time? And whether the treatment is considered as per the size of the fragment, after understanding the biomechanics from Dr. Pankaj. According to me, the criteria for what I choose for treatment is if the arc of movement at PIP joint is 30 to 70 degree in a subacute situation. By the time the edema settles down, pain settles down, and if patient has 30 to 70 degree movement at PIP joint, then irrespective of the fracture pattern, I would consider non-operative treatment or at the most dorsal block wiring, because the result of getting the result of operative treatment with this kind of pre-op range of movement is more or less same. So, for example, this is a 17 days post injury patient, and this is the movement. Okay, he already has. So I would just protect him for another 2 weeks by putting a dorsal splint, and I would start the movement immediately. Versus this patient who has a 19 days old injury, and this kind of a fracture and fracture pattern where there is a comminution in the fracture. Sorry. Yeah. So this is the fracture pattern, and I would consider a Suzuki frame application for this patient just to gain the movement. These are the wire placement for Suzuki frame. And just make sure that the reduction is well maintained. This is how the distraction is achieved, and that is the movement at once the frame is out, and that is the movement that we gain after 6 to 8 weeks of proper rehabilitation. Now, with this, another case that I would like to present here is 28-year-old with the left index finger PIP joint central fracture dislocation with no movement, and it is like 4 weeks post-trauma. And this patient has like a centrally depressed fragment with volar leaf fracture, avulsion and subluxation. And I had treated this patient by distraction, biplanar distractor application, where on table we distracted the joint, and then patient got reasonably good outcome at 3 months, and with total active movement is around 200. So that is how the articular surface restoration also was possible. Then this is a 2 weeks old injury. I thank Dr. Patankar sir for sharing this case with me. And you see the fragment, the patient had a volar leaf fracture fragment, and the joint was mildly dorsally subluxated. But now you see the movement. Okay, this patient had a hardly 30-degree movement at this joint. So in these cases, what sir recommended was we have to treat this fracture by just creating a osteotomy at the fracture site and elevate the fracture with the volar plate. Okay, the moment you do that, so this is the fracture that we created a fracture at. We did a osteotomy at the fracture site and just lifted the fragment along with the volar plate and put a dorsal block wiring. And this patient had a reasonably, well congruent joint, and that's the function. Some part of the flexion deformity can definitely be corrected by a scapular splint. So this is one way to deal with it. Then one more way, sometimes we see a large volar leaf fragment, and if you see his proper anteroposterior view, the fragment is more towards the condylar, radial side condylar fragment, and this fragment is less likely to gain any movement without any intervention. So such fracture definitely required a proper volar approach. You may not need to do a shotgun approach for all the patients, but here I was not confident to visualize the fragment properly. So that's why I did the volar shotgun approach. And then once I did that approach, I fixed it with the 2 screws, and that's a kind of a movement that the patient gained. And in these patients, sometimes they definitely get a flexion contracture, and that can be treated definitely with the Kapner splint. In conclusion, will the conventional method of dorsal splint or wiring work? My answer to this is, if the arc of movement is 30 to 60 degree, 30 to 70 degree, then yes. And will the treatment change as per the size of the fragment? Partly agree. If the fragment is more than 50% involving the articular surface, then definitely it is possible that it may change. But mainly the pre-operative arc of movement is the criteria according to me. Thank you so much. I'm happy to answer any questions if there are. Okay. So if there are no more questions, now I invite Dr. Bipin Gangurde for his next talk. Rohan spoke about acute, I spoke about subacute, and Dr. Bipin is going to give us glimpse of about delayed presentation. Over to you, Bipin. Bipin, please unmute.
Yes, can you hear me?
Yes, very well.
Can see my screen?
Yes.
Yeah. So with excellent talks by Dr. Pankaj Ahire, Dr. Rohan Habbu, and Dr. Parag Lad, what is a delayed type of PIP joint presentation? As Parag said, that up to 30 days, up to 8 to 30 days could be subacute type of presentation. Most of the things which can be done in acute fractures can be done there, like the dorsal block wire. If the joint is reduced well, then you can use a distractor, or you can osteotomize the fragment and then you reduce it. Our aim here is to get a stable, congruous and painless joint. So this is a flowchart which I feel is valid for a delayed type of presentation, in which if a delay is mostly if it is greater than 3 months of and the finger is stiff, the stiff finger can be non-arthritic and stiff, or the finger can be arthritic and stiff. So if it is non-arthritic, then what we can do is we can use a hemihamate arthroplasty, which is an osteochondral graft taken from the dorsum of the hamate, or we can use a volar plate arthroplasty here. If it is an arthritic joint, so it will be a painful joint, you can do a joint replacement, interpositional arthroplasty, and fusion. I don't have any experience with joint replacement and fusion, but rest of the topics I'll cover. So this is a case. If you can see here, this is a 3-month-old delayed stiff finger. However, as you can see here, that there is a good dorsal lip on the dorsum with a significant malunion. There are two ways which this can be treated, like Dr. Parag has shown, that you can osteotomize the fragment and see what is remaining, and if you get good reduction, you might get away with a congruous joint. However, in this case, I would suggest that we do a hemi-hamate arthroplasty. So this is a shotgun approach in which joint is opened completely, as shown earlier as well. And if you see here, there is a significant osteochondral defect and defect on the volar side, which is a very significant big defect, and this has to be corrected by a graft, by a hamate graft, and we can fix it this ways with a hemi-hamate arthroplasty, and to get a good range of motion. So this is the similar type of fracture can be treated with also with a volar plate arthroplasty. I have stopped doing volar plate arthroplasty nowadays. However, this is also a treatment which is available when you are not very sure about the hamate, or you're not very confident in harvesting the hamate. Yes, volar plate arthroplasty can be done. So in volar plate arthroplasty, what we do is that we see the volar plate and we remove it, reduce the joint, and you put the volar plate inside the defect which is created after removing the fracture fragments. So this is a 4-month-old stiff finger. As you can see that the finger is in hyperextension and there is minor deviation in the finger. Now for this patient, a hemi-hamate arthroplasty was performed and it went very well. However, you should remember this, that you should not forget that there is always a deviation. Not all hemi-hamate arthroplasties will really do well, because on table you need to correct the hyperextension and also the deviation, which was not done by me here. So after 6 months, what had happened, that the osteochondral graft collapsed and there was deviation. The joint started subluxating, and after 1 year there was significant arthritis. So what went wrong here? So not all hemi-hamates do well. So you have to realize that you have to plan this hemi-hamate surgery very well. So what we feel that you have to correct the deviation and hyperextension, which I feel that I was unable to correct, and I could not. What Dr. Pankaj had told in the first lecture of biomechanics, maybe that I was unable to really not compromise the forces, and the forces just then the osteochondral graft just gave away, and this has led to this type of problem. And another problem which I feel was that I did not use a bigger graft. A smaller graft is a way more it can cause more problems than a bigger graft. So always whenever you do a hemi-hamate arthroplasty, you have to correct the deformity, whatever it is, and use a bigger size graft. This is a case in which a interposition arthroplasty was done. So this was a complex fracture dislocation. It was around 1.5 months old. The patient came with this presentation. After 1.5 months, you can see that there was completely arthritic and dorsally displaced joint. This joint, this fracture was fixed with a complete hamate. This surgery is performed by Dr. Francis from Kerala. So after this surgery, the patient was not willing to stay in Kerala. So he came to us at 3 months, and this was the picture. So now the patient had a stiff, painful joint to begin with. Then it was distracted, and a full complete hamate was used by Dr. Francis in Kerala. And after that, he came with a stiff, painless joint. So for this stiff, painless joint, you can see that the patient is able to move, but he needed complete range of movement. As PIP joint, he was unable to flex. So interposition arthroplasty, FDS interposition arthroplasty is another way in which a joint can be salvaged. So FDS, the FDP were entirely stuck, which were completely removed from the tenolysis was performed, and the FDS was harvested and it was interposed. You can see a button on the posterior side here, that there is a button there. So FDS is harvested, and after 3 months, after 1 month, you can see that the patient has got significantly good range of movement here. So the aim here is to achieve a congruous painless mobile joint. Hemihamate arthroplasty is a good option. However, we need to know the long-term results here, as the osteochondral graft can really collapse. Arthritic joint can be treated with interposition arthroplasty. Thank you very much, Dr. Parag.
Yeah, thanks, Dr. Bipin. Meanwhile, I invite Dr. Prashant Kamble to share his view. But Dr. Rohan, there are two questions for you from Dr. Devanshu Gupta. Can you hear me, Dr. Rohan?
Screen
Yes,
sharing.
Parag. Yes, Parag.
Yeah. So the first question is from Dr. Devanshu is, what do you do if dorsal wire backs out?
One, I've not had a patient, but if you do, that's why I said it's a close monitoring is required. So every
Okay.
5th day, if the patient comes to you for you to check the range of movement and the pin track, you can use the 2-finger test. Just use your index finger and thumb and try and roll the wire. If it's
Okay.
backing out, then I would actually take him back to the theater, treat it like a pin track, remove that wire,
Okay.
and wash that pin track and use another hole. Don't use the same track to pass another wire. The width of the head of the proximal phalanx is quite good. You need not
Okay.
start in the center every time.
Okay. Okay. And his second question is, how early you mobilize after putting dorsal block wire?
Since it's a digital block, you start moving immediately,
Okay.
and then you keep moving them like right away.
Okay.
Dr. Patankar has something to say.
Yes.
Yeah, to answer the first question, some experience about extensor block pinning or dorsal block pinning is that if you bend the wire, then there is a very good chance that it gets stuck up in gauze or cloth or something and the wire comes out. So I, as a rule, don't bend the wire at all. I just cut it flush. So there is less chance of any external source of pulling out the wire or tugging on the wire. Secondly, by cutting the wire and keeping it flush or keeping it as a plain simple wire, you are preventing any rotational forces acting on the wire. So that also helps to keep the wire in for a long time. We really want the wire to be there for about 3 to 4 weeks. We don't want it for 6 weeks or 3 months. But
Okay.
even 4 weeks it should maintain. So I don't bend the wire like this.
Okay.
Okay,
And
sir.
another idea which Dr. Devanshu had asked the question, another idea is to pass the wire into the opposite cortex. That definitely prevents back out, but that is a much more complicated procedure that has to be done very precisely. And make sure that the wire doesn't come out too much on the front, otherwise it will impinge on the flexor tendon.
Correct, sir. Thank you. Thank you. Over to you, Dr. Prashant. Yeah.
Okay. Good evening, everyone. So just moving from now volar side to the dorsal side, it's the same, more or less, but additional there is a something central sleeve that also will be seeing some of the cases. And let's start with some of the case and how do we manage all of the. So this is a young male patient, had a history of trauma to the right index finger, and as you see, is a X-ray on a PA view, not so obvious looking, but as we say that we must have every true lateral X-ray of your injured finger, and then it will give you a clear idea what it is. And see, this is what you see on the lateral X-ray. So there is a dorsal lip that is a vulse from the base to the middle phalanx, and the volar plate and the other flexor tendons, they are very strong. They are pulling the entire remaining middle phalanx, distal, everything towards the volar side. So how do we treat this? So same, this is a dorsal approach by the Brunner side incision. So you take a Brunner's incision, curve your incision on dorsal side. So these are the two potential side where your incision might stuck to the tendon. But since it is a curved, there is less likely to happen that. And then once you incise the skin, you have three options. Either you go in the center and split the central tendon, or you go between the central sleeve and the lateral band. So that depends on your fracture anatomy, fracture configuration, or something called as a chamois approach, that you start from your apex proximally and the base distally base approach. So this was the approach which was done for that case between the central sleeve and the lateral band. So this was the fracture that has been fixed with the mini screws 1 mm and this 2 fragment, and this was in the AP. And this was the result that you see at the end of 2 months. Both in AP and lateral joint is congruous, nicely reduced. And this was the function that you achieve at the end of 3 months. So another case, you see there is a true lateral X-ray and there is a shattered dorsal fragment and there are multiple small pieces. So it is getting reduced in extension and some amount of traction. So we need to neutralize the deforming force attached to that bony piece, that is the dorsally central sleeve, and on the volar side, volar the flexor tendons and the volar plate. So this was done. So it was neutralized with the external fixator, and the central fragment, which was a pulse, that was fixed with the small size K wire. And this was the X-ray that is achieved when you remove the external fixator. And this was the range of motion that you see at the end of 2 months. So video didn't work. So this was another case recently we saw. You see here both dorsal and the volar lip. Both the lips are fractured. But if you see the joint line, it is very much congruous in both PA and lateral view. So what you need just to immobilize for a couple of weeks, and then you get a good result. So this is just when we remove at the end of 3.5 weeks. So you got a good range of motion at PIP, DIP, and all the joint. So another case. So there is, you can see there is something joint is not looking good, and when you see the lateral, it is what it is. So similar to like earlier case, but that went well. So this was the day 1 presentation. A big fragment volarly, a big fragment dorsally, and the shaft is getting attached, articulated with the head of the proximal phalanx. So what is the workup? Again, under anesthesia, give the traction, fracture getting aligned. So convert these 3 fragments into 2 fragments. Dorsal wire fixed with the main shaft with the 1 wire, and now it is getting subluxated volarly. So what is need? It need a buttress, or it need a support that supports with the shaft of the middle phalanx with the volar fragment. So went volarly, retracting the volar flexor tendons to one side. And what you see, this is a small plate which is available in the mini fragment set. You cut what is required just to buttress supporting, and the proximal screws are holding into the metaphyseal part of the middle phalanx. So this was cut. If you see closely at the tip, so they were converted like a hook, a small hook, which are going to sit and attach to the volar fragment. So this was fixed, and this, if you see that prongs, 2 prongs are holding the volar fragment, and this was the final fixation, and this was what it was initially, and this is at the end of 2 months. You get a good amount of flexion and extension. So another case is this was treated during the lockdown time. So this is a young female patient had something sharp object cutting at the dorsal side, and this how she presented. She couldn't take any treatment for almost more than 3 months, and she presented to us like this. So there is no active extension at PIP joint, so that confirms your diagnosis that central slip is ruptured. And what you need, not the X-ray. Of course, X-ray was done for this patient and it was normal. So what you need, a good ultrasound. So that confirms your diagnosis, and more so it is required how much the central slip has migrated proximally. So this was the local ultrasound done for this patient, and the central band which is quite migrated proximally. So that will also tell us that whether this rupture is complete or partial. So that will also help us to give the treatment. Suppose if this is a partial ruptured and presented acutely, this can be very well managed with the splint, and that can be treated without surgery. For this case, since it was a more than 3 months presentation and the central slip was migrated quite proximally, so we offered this patient surgical intervention. So this was a local anesthesia with tourniquet on, finger tourniquet. This was, the joint is quite supple, and we went through the dorsal Brunner's approach. So this was the Wurz fragment. After mobilizing the fragment, and we made a pilot hole to put the suture anchor, where we are going to fix it with this suture anchor. So this was a small suture anchor, 2.2 millimeter, which is a corkscrew. We just made a pilot hole with a K-wire, and then you can insert the suture anchor, and you tie the central slip to its place where it has a Wurz. And this is what you see in once you prepared it. There is a full extension. Patient is wide away, can actively extend the finger intraoperatively. That will also adjust your tension during the surgery also. So this was the outcome. This was the pre-surgery, and this was the result at the end of 8 weeks. She has a full flexion and the full extension. So to summarize, dorsal lip injury are relatively uncommon, but yes, they are quite unstable. They required proper assessment, especially when you see nothing on the X-ray. Clinically, you can diagnose central slip rupture, and based on your local ultrasound, you can offer the treatment. Whether if it is partial, you can go with the just neutralizing splint that will prevent the proximal migration. And if it is migrated proximally, you can offer and fix it with the suture anchor. And based on your fracture configuration, either that can be fixed with the mini fragment screws, or if it is a comminuted fracture that needs a neutralizing external fixator or distractor and additional K-wire depending on your fracture configuration. Thank you.
Thank you, Dr. Prashant. Meanwhile, Dr. Kiran Ladkar, I invite him to load his presentation, but we will take 2 questions. They are there on the chat box. First question is asked by Dr. Ali Julanda Alamskari. I would like to ask this question to Dr. Pankaj Ahire, that he has asked a question that in event of unavailability of hand therapist or physio, what is the best surgical treatment to avoid least chance of stiffness? Dr. Pankaj Ahire, would you like to address?
I think the first and foremost, what I mentioned in my talk also, and I think most of the speakers will talk about, is getting a joint congruous and getting it in a position where it can be moved early. There is no point getting a congruous joint and then being forced to immobilize it in order to keep it congruous. So your treatment should allow early gliding. Otherwise, all the stabilizing structures are going to get stuck, especially the volar plate, and will not allow it to glide. So as a surgeon, what is in your control is to reduce the joint well and fix it well, and ensure that you supervise the movements of that joint under your direct care. Do not delegate the responsibility of the finger to anybody else. Yeah. For 6 weeks, the patient has to be under your care completely.
Agree. Then question to Dr. Bipin is...
Dr. Patankar had something to add.
Yes.
I just add to what Pankaj just said. If you are taking the patient under your care for 6 weeks, then there is no role of a hand therapist. Anyway,
Yeah.
if your knowledge or if your surgery has been perfect and your knowledge of whatever has happened to the patient is perfect, you can manage all the patients of hand, at least PIP joints, without any need of any therapist, provided you master the 2-3 sprints that are available and patient is compliant and willing to do exercises as per your guidance.
Yeah. Thank you, Dr. Patankar, sir. Bipin, there is a question for both of us, but I think you will you answer this. What are the indication for static distraction in subacute and chronic scenario? So, would you like to take this question? Yeah.
So static distractors also have a role in acute, in subacute and chronic cases. So basically, most of the time, these play a role in chronic cases because you need to distract a joint, create a space. However, whatever you do, you need to, as earlier speakers have already spoken, that we need to create a congruous joint. So as long as you create a congruous joint and keep it distracted, static distractors do work well. But the static distractors have to be for a limited period, and then you start a protocoled guided therapy program, which Dr. Patankar will explain to you later, in which you usually start flexion after not more than 2 weeks. You keep the static distractors and start mobilization early.
Yeah, good. Dr. Devanshu wants to know from Dr. Prashant Kamble that how to immobilize when a stable volar and dorsal fragment case that you showed, how to immobilize that.
So I give the ulnar gutter splint for that patient, which will, since it was a little finger, so that was possible to give me that in the MP joint flex and IP joint in extended position. I checked that in the CM also, whether it is getting displaced or it is stable, and just immobilized for the 3 weeks, and I started the mobilization for that patient.
Thank you. Now I invite Dr. Kiran Ladkar to give a different approach. We have seen dorsal and volar. Let's see the cases that Dr. Kiran Ladkar would like to describe. Over to you, Dr. Kiran.
Just a minute. Am I visible? No.
Yes, we can see you. We can hear you.
Is my screen visible?
No. Share your screen, Dr.
Not yet.
Just a minute. I'll sort that out. In the meantime, you can take some questions, or shall we? Parag?
Can you share your screen?
So, Kiran, you want me to take another speaker? You want me to involve?
Yeah, is that possible?
Yeah, it is possible. Now, I would like to invite our chairperson, Dr. Hemant Patankar, sir, to speak upon pylon fractures and around the PIP joint and how does he manage that? Over to you, sir.
Yeah, 1 minute. 1 minute. I'll just get the thing on the screen. It was ready. Yeah. Yeah. Where is that Zoom thing? Yeah. Yeah. Is it visible?
Yes, sir.
Yeah. I'll be speaking on pylon fractures of the middle phalanx. As you know, a pylon fracture is an uncommon intra-articular fracture of the PIP joint. It causes comminution, central depression, and splaying of the articular surface. Sagittally and coronally, various permutation combinations are seen. And these are very ghastly injuries, but fortunately, they are not very common. So this is one case which presented. This is very, very old case. Now here, the problem is when you are not very proficient and you don't have proper drill, a thin drill, proper K-wires, then becomes quite problematic in treating. Once you must have a clear understanding of the anatomy of the fracture. Second thing which I have seen in practice is that if your patient is prepared to wait for 7 to 10 days, you can manage this with a simple distractor like this. But if your patient, you must counsel the patient, ask him to wait for 7 to 10 days. The fracture ends, the fracture becomes absolutely sticky, and all the fracture fragments fall in place. You may or may not add a K-wire here in this manner. You can add a K-wire in this manner, or you can add a small screw, but really it is not required. If the fragments are so small enough, you may have tricky problems there in passing these K-wires. So if your patient is willing to wait, a simple distractor solves the problem. Now this case, this is the pre-op, that is the 4 weeks post-op, and that is the 1 year post-op picture of this patient, and he has nearly full function of the hand. This is another case. This is a very senior orthopedic surgeon. I had operated him in 1996. The biggest problem is because of it. It is not his dominant hand. It was the left hand index finger, but he was very actively practicing at that time. So he was very keen that the operation should be done as early as possible. I had a great tough time in convincing him to wait for 7 to 10 days. And I think I went there on about 8th day, and just to apply a distractor and just pull the pieces back in place. You can see that the fracture is not very well aligned here. There is a gap seen here, but all you have to have is patience and just monitor the X-rays in this. And now this is the result of this same surgeon, just by simple distractor. This is 14 years post-op, and you can see his function. There is obviously some restriction of PIP joint function here, but at 14 years he was very happy. He was still operating. This is 20 years post-op, and this is 26 years post-op. He has no pain, no arthritis, just by a simple closed external distractor by this method. So this works very well. So this is 26 years post-op. I had a chance to take this X-ray because he had injured his finger again, and there was some problem with this little finger at that time. So this is another case where the fragments were quite big. You can see that there is a central depression here, but that also resolved with an external distractor. And when such a big fragment is there, you can definitely put a small pin across. But the important thing is to first put an external fixator first, get the joint distracted, and then with a closed towel clip or some instrument, something instrument like that, you can reduce the fracture and pass a pin like this. So your pin goes like this, and the fracture remains well reduced. And just to ensure that your fracture is reduced and the joint does not subluxate, I remove the fixators, but I don't remove the K-wires, and then take this final X-ray. This is done about 4 weeks, and you can see that the fracture is healed, the joint is stable, and then you can safely go and remove all the wires. And that is the early function of this patient. Now, this is a tough one. This was a very bad injury. As you can see, very small fragments here. And still, then in these cases, you may or may not require bone graft, but you have to be prepared, counsel the patient for a bone graft, because you don't know after distracting what all articular surface you will see. But fortunately, in this patient, joint reduced completely with a closed distraction, and just we could manage to pin the dorsal fragment back with this small pin here. And again, you can see the same principle we follow, that before you remove the fixator, you just remove the distraction device and take an X-ray, confirm that the joint is reduced well, and confirm that the fracture is healed completely, and then you can go ahead and remove this fixator. And you can see that the fracture is completely healed. Now, very important, while applying an external fixator, you must master the technique or art of placing the pin bang dorsally, because otherwise the fixator will not hold, and in fact will cause pathological fractures. So here you can see that the fracture is completely healed in spite of this very ghastly preoperative appearance. And that is the early function. This is a function after 2 months of removal of fixator. He even has better function. He is not sending me his pictures yet. Now, this is another very complex intra-articular fracture dislocation. Here you can see that there is this central piece which is depressed. There is a volar piece, and there is the whole, nearly whole of the articular surface which is gone behind. So here, what I did is, this was the patient who fortunately presented early. You can see this bruising here in the blood collection, and this was treated with open reduction. And because really speaking, this was a very complicated injury. I said we did not take chance if the fracture does not reduce and is a high profile patient. So I did an open reduction, reduced the joint, and then inserted a pin. You can see again the external fixator K wire is inserted absolutely in the mid lateral plane, so that it gives you perfect distraction here. And then again, before you remove the fixator, you take an X-ray, confirm that the fracture is united. And you can see the perfect placement of these wires here. You can see this wire here. You can see this wire here. It's absolutely perfect. So that is what you should master eventually. And you can see that the fracture is healed completely. And you can see another important thing is when you take an X-ray, go for only dead lateral X-rays. These are the only X-rays that will give you the perfect information. And if the patient is compliant and does not have too much of pain, you take an X-ray in flexion and extension. Okay, this is the extended view. This is the flexed view. Take an X-ray. You will confirm that the joint is stable, fracture is reduced, and this is the function at 6 months post-op. This is a very chronic, I think, patient who presented late. This is another doctor who presented late. You can see that the articular surface is completely collapsed. There is a dorsal fragment here, which is attached to the extensor tendon, and the fracture looks very bad here. So in this case, I have resorted to an external fixator to just bring out the fragments, reduce the joint. And then here, in this case, I did a bone grafting here. And then I attached the extensor tendon with a suture anchor here. This was a Mytech 1.3 millimeter anchor, and that was attached to the dorsum of the middle phalanx with this anchor. And that is the area of bone grafting here. That is the bone graft. And you can see this bone graft. These are taken very simply. You can take it from the dorsal aspect of distal radius. And you can see again the fixator removed, and K wires are there in place. The fracture is, the joint is reduced, the fracture is healed. And you can see that the fracture is healed completely. And that is the long-term follow-up of this patient. Everything is healed completely. And that is the extended view of this patient. And that is the flexion in this patient. Another patient, I think this is the last case. Again, it's a very severe case of pylon fracture represented after 2 months. And you can see that the joint doesn't look good at all. And in this case also, after reducing the joint, I put in the bone graft, cancellous chips taken from the dorsal aspect of the distal radius, and then supplemented and just stabilized it additionally with 2 K wires like this. And this is how the fixator assembly looks. And this is the sutures which are taken after taking bone grafts from the dorsal aspect of the distal radius. And you can see that the fracture is healed completely. And that is the early function pictures. And that is the late function. This was done in COVID. So he has sent me his pictures on WhatsApp. And that is the final result. And that's the final result at that time. So I thank you all for your attention. I can answer questions.
Yeah, thank you very much, sir. It was really a nice presentation. Meanwhile, Dr. Kiran, are you now, can you share your screen? Dr. Kiran?
Yeah, one moment.
Yeah. There is a question for Dr. Prashant that from Dr. Devanshu Gupta, that in acute dorsal slip injury, which is reducible, how to immobilize that in a splint, in flexion or extension?
IP joint has to be an extension, otherwise it will not reduce.
Okay, thank you. Yes, over to you, Kiran.
Am I audible and visible?
Yes, yes.
Yeah. Thank you, team WIROC and the organizing committee. I would like to present on coronal split fractures around the PIP joint, the mid-neutral approach. These fractures are basically extending from the volar lip to the condyles. I think Dr. Patankar showed one of those cases treated. In the similar manner, I have two case examples wherein the coronal plane fracture with some amount of spiral component to it. The first case is a volar lip fragment, approximately around 40% of the articular surface extending into the P2 base condyle. And the second case is a little finger volar lip fragment in a coronal plane. Just a sec. Extending into the P2 base with joint subluxation there. So coming to the next one, case example. The first is a 38-year-old gentleman, is an IT professional. Right middle finger cricket ball injury while catching a throw, and it was a closed injury. If you see closely, it's a middle finger, middle phalanx base around the proximal interphalangeal joint. Very closely, if you see, there is a significant volar lip fragment with the collateral attachments, and there is a impending joint subluxation with a V sign which is seen on the dorsum of the proximal interphalangeal joint. On the right side, I would like to highlight, I have taken a picture of myself with mark on the mid-neutral approach. That's the watershed area between the dorsal darker skin and the volar fairer skin. That's the area where there are only facial or ligamentous attachments, which is devoid of any critical neurovascular structures or the tendinous attachments, the major flexor and the extensor tendons. This is relatively a safe zone. Now, this particular fracture pattern, since it was extending from one condyle into the volar lip, and especially from the radial condyle, we thought of treating this with a single screw here. Now, if you see here, I've used that mid-neutral approach with a stab knife incision onto the middle phalanx base. With a 0.8 mm K-wire, I have made a drill hole, and through which I have inserted a 1 mm screw. You can see the AP view here. I could get a good compression of the fracture surface, and the volar lip also was stable. This is the follow-up at around 6 weeks, and this was the live view. Sorry, if you just allow me to share my screen. This was a live picture intraoperatively. With a screw compression, it was a stable proximal interphalangeal joint, giving a good passive range of motion. This was the movement. This was a straight, good alignment, and this is the follow-up at 6 months. Now, since patient did very well, as in he hasn't come back for follow-up, and he has sent me this video on WhatsApp. You can see a thin scar on the radial aspect of the middle phalanx base, and good range of motion and no extension lag whatsoever. In a second case example, young lady, desk job in the bank. She's right-handed. It was a closed injury to the little finger on the left hand while driving a two-wheeler. This was the presenting picture. On the left hand side, it's a AP view of the little finger, wherein the middle phalanx at the proximal interphalangeal joint is sheared in a coronal plane. The distal fragment is getting displaced on the ulnar aspect, whereas the proximal fragment with the articular surface and the volar lip is getting displaced on the radial aspect. If you see here, we in the same manner we compressed it from the, if you watch it closely on the AP view again, we compressed it with the pointed reduction clamp from the ulnar side, from the ulnar proximal fragment to the radial, from the ulnar distal fragment to the proximal radial fragment. We compressed the fracture, and we could manage to fix it up with a 1.3 mm screw and could get a good alignment. Now, if you see the X-ray again here, there was a joint subluxation, and hence, like Dr. Patankar mentioned in his one of the cases, since there was a subluxation, I neutralized the forces with a distractor frame here, wherein I use this Suzuki type of component. These are the CM images. Subsequently, the reduction is holding onto it well, and we started mobilizing the joint at around 2 weeks time once the skin and the edema settle down. This is follow up at around 3 months, sorry, 6 weeks when we removed the frame. This is the 6 weeks follow up what she had. At 6 weeks after the fixator removal, there was some amount of lag in the flexion of the little finger. But subsequently, at 6 months with good supervised therapy, she has achieved good function. She's back to her overall rigorous training in the gym, and she's further doing the FDP gliding exercise as well, which she wants to get full range of motion in the little finger. So the take home is you have to analyze the fracture geometry well. Good pointed reduction folding forceps will be crucial. Thin 0.8 or 1 mm K wires as a drill guide, and low torque power will be important in getting the good alignment to fix up with the screw, and supervised regular therapy will be crucial at your end. I thank you for patient listening.
Yeah, thank you, Dr. Kiran. That was really good talk and different variety of cases. Now, may I invite senior hand surgeon? Everybody knows he doesn't need introduction. Dr. Sudhir Warrior, sir. So far, we have covered middle phalanx. Now, sir, is going to take us about condylar fractures in the proximal phalanx. Over to you, sir.
Thanks, Parag. When these webinars come around, it's really fun because now you know that WIROC is coming. So it's the harbinger of WIROC now. So you start preparing for WIROC, that eagerness comes in. Is my screen seen?
Yes, sir. Very well.
Okay. I don't seem to be able to advance the slides though. Okay. So I'm going to be speaking about condylar fractures of the proximal phalanx. The things that you need to keep in your mind are the fact that they are intra-articular. So you need to put in all the principles that you would treat intra-articular fractures elsewhere in the body, which means accurate reduction, maintenance of that reduction. During the healing, you need to start early mobilization. Long-term splinting and rehab are absolutely imperative. These things are common for all intra-articular fractures anywhere in the body. So you must not forget that in the hand, there's no difference. So immobilizing them for long periods of time in any position, extension, flexion, whatever it is not a good idea. You need to get them stable enough to start moving early. You must remember, secondly, that they're attached to something. They're not just free-floating fragments that you find on the X-rays. So you must try and think about what can be attached there, and we'll see some illustrations and some cases which will tell us what we're talking about. Remember that this is a key joint of the hand, and if you rob function of the PIP joint, you're not ever going to get good function. So you must be very careful about that. So when you're looking at one condyle being affected, there are different ways in which it can be affected. We'll see a few examples of some of these. So as you look at on the left side, you can see that there is a fracture of one condyle, the other is intact with the metaphysis and the rest of the bone. In the second illustration, there is a similar fracture, but extending down into the metaphysis. And the other two illustrations are showing these are coronal splits, which are basically either sloping volarwards or dorsalwards, and these are all highly unstable fractures. When you're looking at bicondylar fractures, what you see then are that the articular surface is now split. And once they are split, you must remember that they're still attached to those collateral ligaments, and they can flip in one side or in one direction or the other direction. And of course, if there is a metaphyseal extension, or if it's a multi-fragmentary fracture, that makes it that much more difficult to deal with. So unicondylar fractures, remember that the displacement is dependent on the revolution of that fragment, depending on what it's attached to. So similar to what you see on the diagram, you see an X-ray where you find that it doesn't look, if you look at the PA view or the AP view, whichever one you've taken, you do realize that it's not badly displaced, or it looks chalta hai, we can manage this kind of thing. When you look at the lateral, you realize it's completely flipped. So you need to reduce this. If it's an acute one, you can do a close reduction. I joystick this one into place, and I use two very thin wires to try and fix them down. So remember that you have to use 0.6 or 0.8 millimeter K wires. Do not use any thicker wires, and we'll see why. And that is the result at the end of 6 to 8 weeks. And they go on to do very, very well if you mobilize them right from the beginning. Should you use a screw? Of course, you can use a screw. What is a screw? Basically, a screw is like a K wire with threads and heads. So basically, you're trying to pin down something. A screw is a little more secure. At 1 millimeter, that security is very, very little unless you place the screw correctly. So be careful. Screws are not panacea. Screws are not absolutely essential, but they are helpful and definitely a little better than K wires alone. But with screws come the problems of getting there. So you must see to it that you do not impale collateral ligaments. So you need to be able to identify the collateral ligament, retract it, find the surface where you want to put the screw in, and let the collateral fall back. What if that's not ideal? If that is not ideal, then you need to then split the collateral between the proper and the accessory collateral ligaments. So you need a little more technical or a little more dissection skills here. And then you can put in your screw to get you a good result. How do you get to the collaterals? It's nice to say, mind the collaterals and things like that. But when you open it up, you've got the extensor hood. And that's a very complicated arrangement of anatomical importance that you need to pay attention to. So you must skirt the lateral band. And in the lateral view, when you see this, you have to go in from there, right underneath the lateral band, lift up the entire extensor expansion, and there you will find the collateral ligaments underneath that. What about these fractures where there's a condyle involved but extending into the metaphyseal region? You can use multiple screws. Now, if you're using multiple screws, remember the screws have to be of an adequate size, and also you must remember that these screws must go in with all the principles of fixation. That means one screw head on all sides of the fracture or of the screw hole should be available bone, and you should divide your screws into equal portions of the fracture length so that you're able to get a good stable fixation. Here's a fracture which was a coronal split, which looked innocuous. Again, if you just look at the X-rays, you might say, "Theek hai, let's just conserve him," etc. Until you see that when he flexes, it knocks down the fragment, and if that is so, it's a very unstable and going to be a very painful joint if you don't put it back. For this, you need to go in from the volar aspect, a Brunner incision. You need to then open up the A3 pulley, take the flexor tendons aside, take the volar plate down as seen here. And once you do that, you'll find the fragment. This is the actual case. The earliest images were from another case. So it's a very small incision here. And now the condyle is looking at you. You flip it back and pin it down with a wire and fix it down with a screw. And that's how it looks later. You may sometimes require a couple of screws. These are 1 millimeter screws. I would not put any thicker screws than this, and you can get a fairly good result. A chip like that, again, looking innocuous innocuous, but when you see the middle image, you realize that it's a huge depression that the middle phalanx is going to ride through instead of on the head of the proximal phalanx. So this has to go back in. And that's how it's flipped out. When you open it, here in this case, there was an extensor tendon injury. So we had to open it from there, flip it back in, put it down with a screw, repair the extensor tendon, and then mobilize him. Here, screw lengths are absolutely important. This screw is erroneously a little longer. And sometimes when you get the screw sets, you find that the screw sets are deficient in a certain size. The second problem with using 1 millimeter screws is to try and get the depth gauge in. Sometimes it's not very easy to do that. So you take, you eyeball it and you try and do it. But I would not put a screw repeatedly and change it. If I'm using one screw, if it's a little longer, and if I think it's not interfering with the flexor tendons, I might just leave it in a little longer. Then that's what we did in that case. Just because you have implants, don't use them. So here's a threaded, a cannulated head, so-called headless screw. And I think rather than the screw, it was the surgeon that was headless. You don't use such large implants without accurately reducing the condyles. It only makes it worse for the patient. So check your implant before your surgery. Let's look at bicondylar fractures quickly. So these are a little more tougher to treat. Something like this can easily be put back. It looks good. The middle phalanx is riding well. All you need to do is to hold the stability and allow the movements. There may be just a little bit of forward translation. And here I've used wires which are 1 millimeter, and just look how different it looks. It's too big. It should have been a 0.8 or a 0.6 wire, which would be adequate. Maybe 0.6 is too thin. Maybe a 0.8 would be ideal. So this is just too thick. Shouldn't use this. You can get avascular necrosis of parts of the condyle or the complete condyle, which I have had in a few cases. But it can give you excellent results just with simple K wires. Same thing now displaced. And if you see the lateral view, both condyles are flipped. When they're flipped, you need to approach from both sides of the central slip. So now you're looking on the dorsum. And you look from one side, then peep in from the other side. Get one condyle in, get the other one in. Once you've got both the condyles in, pin them down. So now here you see there are 4 wires. One wire first to hold the 2 condyles together. The second wire to hold the one condyle down to the main fragment. And then the other condyle to the main fragment. I wasn't satisfied with that, so I added another pin. This could have done with just 3 pins, but I had to use 4. Whole aim to maintain the articular surface. And if you look on the right, you'll find that the sphericity of the head is very well maintained, despite the fact that there's a volar lip fracture, avulsion, and also a partial avulsion of the extensor central slip. So despite all these injuries, and despite the number of wires, just the size of the wires and their position and early mobilization can get you excellent results in a very, very tight situation. So you need to just understand what you're doing and then carry on. What if you miss the bus? If you miss the bus, then this is what happens. Here's a surgeon who's the head of department of orthopedics in a hospital. And he was fixed by the plastic surgery department there. And unfortunately, the wires fell apart. The joints were looking bad. And if you look at the circled image on the right, you find that the entire middle phalanx is sitting on a spike, is perched on top of a spike. So he's not going to get any movement. Again, you're peeping in from one side. And what you do is you get one condyle in, get the other condyle in, fix it down with a screw and a K wire in this instance, maybe 2 K wires, maybe 2 screws, depending on what you have. There are times when you may need to go in from the center. So you need to split the central slip like was done here, where there's a strip of the articular surface that's come out. And there are times when you may have to do what is known as a chamois approach. So when you need to do a chamois approach, you can see the condyles well, but then the rehab of this one is a very difficult rehab. So don't use this very lightly. So instead, in this case that we were following, I've gone in from both sides. I've peeped in from both sides of the central slip. and managed to get a fairly good surface. I'm sorry, I'm not going to waste your time, but trust me, he's now a prolific arthroplasty surgeon. He's doing fairly well, and the joint has stood the test of time. He's now retired over the last few years. So finally, in summary, condylar fractures, you must remember that they are intra-articular and always will be unstable. Unless you reduce them and stabilize them, you can't start early movements. That is the whole aim of intra-articular fracture treatment. The soft tissues have to be respected. As you saw through the lecture, there are different structures that you've got to pay attention when you're trying to get to a particular surface of the joint. And most importantly, what you don't see through any of these lectures is the fact that a lot of time goes before you can see the good results. Thank you very much for your attention.
Thank you so much, sir. Thank you very much. It was a really wonderful talk. Now, I would like to invite Dr. Nikita Shetty, and she's really going to address a very important problem that about the stiffness. Yes, over to you, Nikita.
Okay, good evening, everyone. I hope I'm audible and
yes, very well.
A lot has been spoken about how to manage fractures and how to mobilize it or immobilize it in the previous lectures. Now, I'm just going to go through a few cases where what happens if these joints get stiff and if they do not receive the appropriate treatment primarily. So here's a 2-week-old cricket ball injury in a young gentleman, came with a stiff PIP joint in extension. There was no active or passive flexion at the joint. And that was his X-ray. So now there is no obvious fracture at the PIP joint. The condyle looks okay. The middle phalanx looks okay. But if you look closely, the PIP joint is hyperextended. So like we saw in the first talk by Dr. Pankaj Ahire, the volar plate that is attached to the base of the PIP joint has probably come off. That is the volar restraint of the PIP joint, which is causing this joint to hyperextend. So that is what we found in a sonography. And we also found a small flake of bone, could be a cartilage piece that had come off with the volar plate. The MRI did confirm a avulsion of the volar plate from the base of the middle phalanx, and you can see that it's protracted and it's lying down at the level of the neck of the proximal phalanx. So now this patient did have this injury. The joint was in hyperextension, and what usually happens with these patients is they're immobilized in extension. They are just put in an extension block, an extension splint, or the body strap in extension, and this makes it all the more worse. So here the treatment was not extension immobilization for him. So what we did, the volar plate had avulsed from the base, so we went in volarly. Through the Littler's approach, the joint was cleared. We identified the avulsed volar plate. So once you identify the volar plate, what is important is on table, achieve passive flexion before you reattach the volar plate, because now the joint is stiff in extension. So under anesthesia, manipulate the joint to get passive flexion and make the joint supple, and only then go on and attach the volar plate. So that will help you overcome the extension stiffness. So there it is. The volar plate reattached with a anchor in the base of the middle phalanx, and that's the patient at the end of 2 months with full range of motion. So this was a year-old volar plate avulsion injury, again managed multiple times conservatively. The joint was now in fact in hyperextension, no passive flexion, and if you can see the DIP joint that is going into a compensatory flexion, giving the finger a swan neck deformity. On getting an MRI, the volar plate was in fact avulsed. The joint was in hyperextension. So we decided to go in volarly, did an arthrolysis, but in spite of clearing the joint and doing an arthrolysis, we could not achieve any flexion, not even passive flexion. The joint was very tight in hyperextension. So now we realized there was something more than just a volar plate injury. There was something else holding it back. So if you pay attention, the MRI is a static image. it won't show you what is happening when the joint is moving. So we decided to do an intraoperative ultrasound. These days, ultrasound machines are available in almost every hospital in the operating theater because anesthetists are using it. And you can register yourself under PCPNDT Act. And if you have a good sonologist friend, you can train yourself to see the structures in the hand. So we saw this under an ultrasound in dynamic images and saw that the lateral band was in fact adherent on the dorsum, and that was what was not allowing the joint to yield in spite of all the force that we were putting. So we went in dorsally through a separate incision, released all the lateral bands, did a good tenolysis. This patient did have a prolonged and difficult post-operative period because of the double incision, the multiple procedures. But at the end of it, he regained a good functional range of motion and hasn't complained since. So here is a 5-month-old injury. If you look at the X-ray here, you can see that the radial condyle has fractured and is depressed down. And this is manifesting in its clinical appearance where the finger is deviating towards the radial side. And on the lateral X-ray, the condyle also looks like it is flipped. So now this patient had deviation and an extension contracture. So make sure that you're correlating your X-ray findings to your clinical findings to know exactly what the problem is. So here, because the condyle was flipped and was malunited, and it was 5 months since the injury, so we decided to get an MRI done. The head of the proximal phalanx did not look very good. Now, this was a professional athlete at the middle of his career and was desperate to get back to his game as soon as possible with painless range of motion. But because of the status of the head of the proximal phalanx, we planned an exploration and osteotomy, but also consented him for a fusion if the joint did not look good. Now, this patient also had an open injury during the first time he got injured, which had an extensor tendon injury, which was sutured at the time. So we decided to spare that area and we took a chamois approach, lifted off the extensor, did a tenolysis, reached the joint, did a thorough arthrolysis, and when we look closely, the condyle actually didn't look very bad. The articular surface was fairly good. And after the arthrolysis, when we manipulated the joint to get passive flexion, he had good passive flexion. You can see there's almost 90 degrees of passive flexion there. So the extensor was sutured. The patient went through a good post-operative rehab. Like Dr. Warrior mentioned, in a chamois approach, the post-operative rehab is very critical and a little different from other rehabilitation. So make sure that you're monitoring the rehab. And that's the patient 8 weeks from the time of the surgery with good painless range of motion, and he got back to his sports in 6 weeks. So now what if there is a bony involvement like this? This young kid came with a pediatric epiphyseal fracture dislocation. He came at 4 weeks, and if you look at the X-ray and the CT scan, you can see that the condyle is fractured, but with that, the middle phalanx has also gone back. So we went in through a midline approach through the extensor, and we found that the condyle was folded back. And if you see distal to the condyle, that is the epiphysis of the middle phalanx, which is also dislocated along with the condyle. So this condyle was slowly prised open. Make sure that you're very careful because sometimes these fragments can be very small, thin fragments. And if you don't handle them well, you can just crush them. Or if you strip off all the soft tissues from them, they can eventually go into avascular necrosis, and then they just disappear right in front of you on sequential x-rays, and you just can't do anything about it. So make sure that you handle these fragments with great care. So the fragment was put back and we fixed it with a wire through the joint, stabilizing the fragment. So this was a cricketer at a make or break point in his life with where his career was going. Had an injury which was mismanaged for 8 months, underwent physiotherapy and all sorts of things, was out of the game for 8 months. Had a very weak grip because it was his bottom hand and he couldn't grip the handle of his bat. So it was difficult for him to bat because it was not a good grip. So when you look at that image, you can see that the little finger where if you make a fist, you'll realize that the maximum strength of grip comes from the little finger and the ring finger. So if he can't hold the bat with the little finger, it's very difficult for him to bat well. So there was his X-ray. On the lateral view, the joint has dislocated dorsally. There is a volar lip fracture. There's some newborn formation because the joint has stayed in that position for 8 months. And the middle phalanx base is hinging over the head of the proximal phalanx. So what this does, it eats up the cartilage on the proximal phalanx. And because these patients are undergoing physiotherapy, the physiotherapist is forcing motion at the joint, it is going to just eat up the cartilage on the proximal phalanx head. So we got a cartilage sequence MRI done for this patient, and the proximal phalanx head and the articular surface did not look very good. So we counseled the patient that the best way he could go ahead with the sports is to get a fusion. Now, in what position do we fuse him? What is the ideal position for fusion? So ideally, the recommended position, the angle for fusion that is given for the little finger PIP joint is 55 degrees. But was 55 degrees a good position for this particular patient because of his sports? Now, their bats, the handle of the bats and the rubber and the silicone grip varies. So everybody has a very different silicone grip. And 55 degree is not a very good angle for him to take a catch. It's quite a bit in flexion, and he can't take a catch in that hand if the finger is in so much flexion. So what was the ideal position for this patient? So what we did is we asked him to get his back, asked him to hold the angle. We took a transparent sheet and we drew the angle at which the little finger PIP joint, he had a good DIP range. So we drew an angle at which the PIP joint could go and grip the bat, and that came out to be around 35 degrees. So fusion was planned. The joint, we planned to fuse the joint at 35 degrees angle. But when we went in and did a thorough arthrotomy and cleared out the arthropibrosis, the joint did not look very bad. If you see closely, the volar part of the head of the proximal phalanx, which basically where most of the flexion of the joint happens, was not very bad. So now we thought that there is probably still a chance that he might get a painless mobile joint. So we took a bet. We decided to just go in. We removed all the small fragments, all the loose pieces that were around. We reattached the volar plate and then mobilized this patient. And that's him 2 months after the surgery with a good range of motion. He then went on to play in IPL that year and has played for the country. So I showed you all the surgical solutions for an extension contracture. Now let's look at this patient who came to me with a cricket ball injury. He came to me 1 month after the injury. And the first time where he consulted a doctor, he was given this splint. This splint is, I think, the most ghastly splint that is available, and people think that it is the solution for everything. But if you look at his finger, this patient had not removed the splint for a month. He had a pressure ulcer on the volar side. The skin was macerated. The skin condition was so bad. And this was his middle finger that was sticking out. He could not flex it. So it's not a very nice thing for the middle finger to be sticking out all the time. So when I got the X-ray, he did have a volar lip fracture, but the fracture seemed like it was uniting. The articular surfaces were looking good, but the joint was in hyperextension. So I explained to the patient that I would like to give him a chance of close reduction in the OPD under a ring block to see how the joint yields. So under a ring block, that's what I did. I did a close reduction and could achieve very good flexion, and the joint looked congruent. There was no crepitus. So make sure that there's no crepitus and the joint is congruent. So then I immobilized him with buddy strapping. So when you're taping these joints, make sure that it's very light tape with the adjacent finger. Use paper tapes, they're the best thing to use, and keep them away from the joint so that the patient can flex the joint. And I gave him an extension block splint. In the previous lectures, we've seen what an extension block splint is, so I'm not going to go into it. So give a splint in a functional position of the PIP joint in flexion, because flexion is the aim of the treatment and the joint is stable in that position. So that's him 10 days after the reduction with a good mobile joint and a stable non-crepited joint. So things to remember is a thorough clinical examination, appropriate investigations to first identify the cause of the extension contracture. Arthrodesis, I would always keep it as a last resort. Try to give the patient a mobile joint as long as it is not painful. Post-op rehabilitation, as everyone has emphasized before me, a closely monitored post-op rehabilitation is the key to getting movements, because most of these stiffness is because of inappropriate, unnecessary immobilization for long periods of time. So have a good post-op rehab for every patient, and sometimes surgery may not be necessary. So see the patient, see what the problem is, look at the x-rays, look at the patient clinically, and like I showed you the last case, sometimes just a close reduction under a ring block can be the solution. Thank you.
Thank you so much, Dr. Nikita. Now I would like to invite Dr. Pankaj Ahire to speak upon arthrodesis of PIP joint. Over to you, Dr. Pankaj.
Yeah. You saw the case that Nikita showed that, she was planning an arthrodesis and she opened the joint and she felt there was no need of arthrodesis. Not only for arthrodesis, whenever I have open joints for some other salvage procedure like a volar plate arthroplasty or a hemiamate, more often than not, I am tempted to reconstruct the joint rather than do some kind of a replacement. I think PIP joint in that respect is a fairly well-tolerant joint. And as I mentioned in my first talk, as long as you get the joint to glide instead of hinge, even with a very poor articular cartilage, it will do well. There may be another reason why a PIP joint, when you surgically open it and you decide to, not go ahead with a plan of sacrificing the joint, and it lands up doing well. We'll come to it little later, why they would still do well. And as you would have realized through all the talks, arthrodesis almost did not feature anywhere. And I must admit, I don't remember the last time I did an arthrodesis of a PIP joint. It was probably 2 decades ago. So it's not a very common surgery. So most of my talk is not going to be based on my personal experience, but based on experience of others who are doing these type of surgeries. I think one of the most beautiful record of digital arthrodesis was presented by Moberg in 1966, and he put forward very simple 3 conditions. He said a prime requisite of a good digital arthrodesis is 1, it should be a painless and stable union. 2, it must be in proper position, and it must occur in a reasonable space of time. I think he just summarized everything that needs to be said in this talk, in these 3 things. And we will see how these 3 things can be achieved. So Moberg presented a number of cases. I think he presented about 89 cases of PIP fusion. And his go-to procedure was to take a bone peg from proximal ulna and shove it from the proximal phalanx, from the cortex, to the medullary end of the proximal phalanx, and then into the medullary canal of P2. There was a lot of emphasis on preparation of the condylar surfaces, that is excision of the joint. So he used 4 procedures: bone peg from the ulna, then he took a tinier peg and with K-wire, and then with K-wire, and there was another one which he said just excise the articular surfaces and put a plaster. And this was his analysis. Of the 89 PIP cases, only about 22 were done for intra-articular fractures. So that also tells when the essentially a healthy joint which has got injured, healthy articular cartilage which has got injured, will very rarely end up going into an arthrodesis. Whereas if there are other factors which will render the joint not very useful, that is more likely to lead to an arthrodesis. So Moberg's 89 joints all had union, and almost all had union, and 4 had only fibrous union, and they all united under 8 weeks. So 8 weeks is what it takes for these tiny bone ends to fuse and give us very sound arthrodesis. That was in 1960. Almost 60 years later, a review of 74 years of PIP arthrodesis, almost 2000 PIP arthrodesis were evaluated. And as against the 4 procedures which Moberg evaluated, 4 different types of fixations, this review had 12 different types of fixations. Out of these 12 fixation methods, the best and the worst method, both were different from the Moberg's 4 procedures. So Moberg's procedures were probably something optimum, and over a period of time, something better came out and something worse came out. We'll see what those were. So of the 12 techniques, the 3 commonest techniques that were used were K-wires in almost 750 cases. And then was tension band, and then was compression screw. The common to all these, and also, of course, intraosseous wire. Common to all these things was compression. Okay. So the remaining 8 techniques did not give compression, whereas 4 techniques gave compression. The compression screw had the best outcomes, and the intraosseous wiring had the worst outcomes in these 12 techniques. As I said, these 2 techniques were the ones completely different from what Moberg had presented 60 years ago. So compression seems to be the principle to achieve what Moberg proposed: painless, good position, and in a reasonable time. What are the indications for arthrodesis? More often than not, it's a systemic arthritis like RA causing complete joint destruction. So not a contained defect of an articular cartilage, or not a step that would happen in a trauma, but a generalized degradation of the articular cartilage. Along with that, a ligament dysfunction. The joint is not only arthritic, it is unstable and deformed, and sometimes deformed and fixed, or deformed and is stiff in a non-functional deformity, something like a stiff swan neck, or a stiff boutonniere, or a post-burn stiff contracture. So the fusion may be required simply to get the finger in a good functional position. And of course, then you have osteoarthritis. Primary osteoarthritis is quite uncommon in PIP joints, and the secondary is what we are talking about after trauma or infection, in trauma being much more common than infection. So in osteoarthritis, you can either have a stiff PIP joint in functional position, which is not such a bad situation, which is kind of a fibrous ankylosis, or you can have a painful joint, which is fairly mobile. So not a very uncommon situation again. So in these cases, fusion becomes a relative indication, because it's a functional position, it's a mobile joint. You don't want to convert a stiff functional finger into a stiff functional finger by arthrodesis. Nothing achieved, and you may not want to sacrifice mobility in order to make the joint painless. So these become relative indications. If you have a mobile and painful joint, one of the options that you have is what is called as denervation. Now, denervation is a fairly well-established procedure when it comes to arthritis of the wrist. In fingers, it is not very commonly used. Now, if you see this diagram, this is the proximal end of the digital nerve, and my arrow is now tracing across the distal end. This is the proximal phalanx, and this is the middle phalanx. And you see the number of articular branches that are going from the digital nerve to this. Now, if you divide these branches, then the joint can get denervated. Both digital nerves give a number of branches, and there are hardly any, or there are practically no articular branches on the dorsum. So on the volar side, if you do denervation, a mobile painful joint may be converted into a mobile and a painless joint. And there are reports of almost 80 to 90% of patients getting better range of motion after denervation. One of the things that happens after the extensive procedures that we do on the volar side, say like a shotgun approach and an arthrolysis, or when we do open reduction internal fixation. I think some of the credit for success of those procedures also goes to an extensive approach that we do on the volar side, and leading to some amount, and that could be leading to some amount of denervation of the joint. And therefore, arthrolysis really, really works very well in PIP joint. So real indications for arthrodesis in PIP joint in digits remains an unsound ankylosis and a painful stiff joint, more or less one and the same. So unsound ankylosis can be poor position, it can be deformity, or it can be a painful ankylosis. So for the middle ring and little finger, okay, still arthrodesis may not be a great choice, because forget the middle finger. Middle finger, I think, belongs to both the parties. It belongs to the ulnar digits also, and it belongs to the radial digits also. For the ring and little, as Nikita very rightly said, the little finger and the ring finger take part in a power grip. So arthrodesing them in a optimum position for many activities, which may include a small object grasp and a large object grasp, may not be easy. You might make it appropriate for one activity and inappropriate for another. Therefore, perhaps an arthroplasty of some kind, either an interposition arthroplasty or an implant arthroplasty, is a good idea for the ulnar 3 digits or the ulnar 2 digits. Here, the lateral instability is one of the factors in a joint which has been destroyed, which probably is less important in the ulnar digits, which may be far more important in the radial digits, as we'll see. And therefore, in order to get good flexion power, a silicone arthroplasty is probably a better choice for the ulnar 3 digits. Middle finger, you should always evaluate depending upon the patient's activity levels, where you should consider it, whether you should consider it as an ulnar digit or a radial digit. In the thumb and the index finger, the situation is a little different. If you see the 3 types of grips that these two digits take part in, the 2-point pinch, or also called as a pincer grip, a 3-point pinch, also called as a tripod pinch, and a lateral pinch, also called as a key pinch. In all these things, stability of the PIP joint takes precedence over the amount of flexion arc that you need. And therefore, for index and thumb, arthrodesis may be a better choice than implant arthroplasty. So till now, what we have seen is joint destruction plus lateral instability probably is headed for arthrodesis. In an index and thumb, definitely arthrodesis is probably better than any kind of implant arthroplasty. And if you want to achieve good arthrodesis, you need to use one of the compression methods, much more successful than non-compression methods. And despite all the success of the headless compression screw, K-wires are still the most common. Compression arthrodesis can be achieved by various means. It can be achieved only with K-wires, or it can be achieved with TBW. It can be achieved with an intraosseous wiring, but intraosseous wiring has its own problems. The problems with intraosseous wiring have been very nicely analyzed in these articles, but I will not delve deeper into it because it is not a very commonly used method. Of course, wherever there are bones, there will be plates. Even plate arthrodesis has been evaluated, has not fared as well as the compression screw. So compression screw probably remains a gold standard for achieving a good digital arthrodesis. And the procedure is almost same as what Moberg had proposed for his peg bone graft. It's a dorsal approach. The extensor slip can be sacrificed given that you are going to arthrodese the joint, so you don't need it to glide. Remember that it is a lag screw, so you always drill the proximal cortex, over drill the proximal cortex, and you completely bury the screw. Advantage is because of a good compression, not so even preparation of the articular surfaces, the excision, the arthrodesing surfaces, can also lead to a good fusion because of the compression. And because it's a implant which is in the intramedullary, it is mechanically much more sound and therefore will withstand the stresses of the across the joint for much longer period of time than a K-wire or a tension band will. And I think therein lies the success of headless screw. Optimum position, as Nikita told us, the optimum position for PIP joint needs to be a progressive flexion from radial to ulnar digits to maintain a cascade. So it probably ranges from 40 degrees for an index finger to around 60 degrees for a little finger. You need to carefully evaluate what is the most important function that the patient wants this hand to be operated for, and accordingly decide the degree, as was very beautifully demonstrated by Nikita in the case of a cricketer. So to summarize, if you want to do arthrodesis, please aim for a compression arthrodesis, because you will get a sound arthrodesis in a reasonable amount of time. Thumb, index, and probably middle finger are better choices for arthrodesis than little finger and ring finger, where flexion arc is very, very important. And if there is no lateral instability, consider arthroplasty or denervation instead of arthrodesis. Thank you very much.
Thank you so much, Dr. Pankaj Ahire, for this nice illustration. And I know we still have 3 minutes, and I would request Dr. Patankar sir to summarize the entire and give a glimpse of, he has a nice presentation on the last topic that he wished to present. Let him only comment about it. Over to you, Dr. Patankar sir.
Oh, shit. Sorry. One minute. Am I being seen?
Yes, sir. Yes, sir.
I think some other presentation has come back.
No, sir, we are able to see no fracture, no dislocation.
I am not able to see that.
You exit the screen and then see again if you want.
Okay. I'll share again.
Yes, please.
1 minute. I think this screen. Yeah. Can you see this now?
Yeah, but
Yeah.
make the full screen. Yeah.
Yeah.
Yes,
Yeah.
sir.
So we have seen all the speakers have presented the various cases of fractures around the PIP joint, fractures of the base of the middle phalanx, proximal phalanx, with such clarity. I'm sure that everybody has understood the problem and the solution to that. However, there are many cases where we either see no fracture in the PIP joint on the lateral view, or else not a frank dislocation, but there is a volar lip fracture. And we assume that there is no problem in that. Is it so? I disagree with this statement. I want to make you alert to this problem. Even if there is no fracture or no dislocation seen on the X-ray, one must be very careful of these blunt injuries of the PIP joint, where the X-ray is often labeled as trivial, where the injury is very trivial and the X-ray is normal. So these, because of the trivial nature of the injury and normal X-ray, these are most neglected. And you can see this example where there was a history of blunt trauma. The lateral view does not show any fracture dislocation, and the patient presented with a slight flexion contracture. This usually gets corrected with a small splint like this, a dorsal gutter splint, even if the patient present after 7 days. But unfortunately, ignorance on the part of the doctor and neglect on the part of the patient and non-compliance by wearing the splint leads to a greater problem in terms of a flexion contracture, which is very, very disabling. And not only disabling, it is a social stigma because the patient's finger looks very crooked, and then they come for treatment. So the same patient presented after 2 months for the treatment. Another not so very common problem with these trivial injuries is an extension contracture. Nikita, I know, has presented, but her cases are much more complicated. These are simple cases, but the patient has presented with a severe extension contracture of the fingers. Now, we have early presentations, late presentation, and very, very late presentations. So, whenever you have a blunt injury of the PIP, blunt injury where there is a swelling, you should always note whether there is a soft tissue edema. Now, these are the cases where there is the highest risk of flexion contractures if these patients are not splinted for about 2 weeks in extension, in addition to giving anti-inflammatory drugs. So, this is a very ominous looking pattern here. If you are not aware of this, there can be problems. Now, a simple splint, you can ask the patient to remove the splint, but make sure that he applies it with the finger straight. And you can ask the patient to apply ice and give NSAIDs. And also at the same time, patient must do active DIP joint exercises to get over the problem. Now, a simple splint can be constructed in a clinic with a syringe and a padding, and you can apply it like this. Obviously, in all these patients, if the PIP joint is going to remain stiff and not mobile, DIP joint exercises are very important in these cases. Now, this case presented very recently as an acute injury. Now, again, there is a volar lip fracture. Patient is having a full extension of the finger. But in this case, patient cannot actively flex the finger. Now, this patient is very painful. In this case also, if you give a dorsal gutter splint, there won't be any problems. This splint has to be maintained for 2 weeks. After 2 weeks, you mobilize her, ask her to actively flex it. And in the night, she should keep it extended for about 6 weeks. Now, patients don't present that early. Patients don't present immediately. They don't take an X-ray. They don't take a dead lateral view. And this patient presented late, about 7 days later. She was not being able to correct. You can see in the oblique because just a small flake. Again, this does not sound good for the finger. Patient presented with a flexion deformity. Patient cannot actively extend it. There is pain. So here a Kapner spring was given. So dorsal gutter splint and a Kapner spring, these are the two most important splints for PIP joint rehab and mobilization and for recovery of the flexion contractures. Now this patient, in 14 days, she was able to completely flex and extend. However, I advise her to maintain the Kapner splint at rest and in the night intermittently for further 6 weeks. Now this very typical example, a late presentation, patient is having a flexion deformity. Obviously, active extension is not possible. So how do you know that the splint is going to work? So if you passively try to extend the patient finger and the patient gets pain, that means that the patient is going to respond to a splint. This is a very simple test which tells you that the patient does not require any sort of further treatment or any surgery, but he is going to respond to a Kapner splint. Make sure that he follows up with you. Make sure he wears the splint properly. And this splint works by passively stretching the finger. Obviously, there are a few things about the splint which you must take care of. This one thing is that if the hinge of the splint is at the level of the PIP joint, there is maximum pain because there is maximum stretch. So you can teach the patient to slightly slide the splint proximally. Here the pain and stretch is reduced. So patient should be treated for self-adjustment for pain control. Another thing is beware if the patient has a prolonged flexion contracture, you can have vascular blanching or vascular problems with this Kapner splint. So beware and make sure that you understand it and the patient understands it before he leaves your OPD. Another thing is this splint can cause pressure problems. So you can pad it with strips of paper or folded sheets of paper like this to prevent skin ulcerations here. So this patient did very well. And this patient, because he was looking non-compliant, I asked him to wear this splint for 3 months. And that's the result. Now, again, we come to a very glaring example of neglect. This was a patient who presented in January 2012. I advised him splint and to passively stretch it, but he refused to wear the splint and he came with a flexion contracture and then landed up 3 months later with a severe flexion contracture of the finger. Now, in these cases, there is another patient. This patient presented with a flexion contracture of 2 years duration with a normal looking X-ray. In these cases, they are not amenable to a splint, and this you have to treat it by a volar exposure. In most of the times, you don't have to go to the volar plate. many times in all these cases, many of these cases, their flexor sheath is the one which is tight. And so you have to just release the sheath on both sides. If you don't get a correction, then only you should go to and release the volar plate from the base of from the head of the proximal phalanx. If there is very severe problem, then only you can consider release of the flexor sublimis, one slip or both the slips. So in this case, the patient responded only to a release of the flexor sheath. Volar plate release was not required. Passive stretching corrected the deformity. You suture the skin here, and that is the result, long-term result after wearing a Kapner splint. So very rare cases, they're not very common problems, and that's the extension contracture. In this case, it was a fracture dislocation, which was treated by a close reduction, and the patient was splinted in extension, and patient failed to achieve active flexion of the finger, and he had a stiff finger. So this is the splint that I use, a single finger flapper splint, which I use. You can titrate the pain. You increase the rubber bands depending on the pain, and gradually stretch out the finger like this. Gives you passive flexion. And in the same time, when the pain is reduced, you can ask the patient to actively extend the finger with the same splint, and that is the result. That is the extension, and that is the full flexion with the simple splint. Another case, in this case, it looks like a swan neck deformity, and this is the X-ray which is normal. And we did a sonography of this patient, which revealed all sorts of volar plate injuries. But here, before you jump into surgery directly or go send the patient to physiotherapist, you should try with this splint, which is a single finger flapper. And gradually you can increase the rubber bands, strength of the rubber bands as the pain is tolerated. And you can see that patient gets very good flexion. And initially he may have some flexion contracture that can be corrected with a Kapner splint. And this rubber band traction splint can be worn at night and gives you a very good result. To summarize, PIP joint flexion contracture, the threat is real. Prevention is better than cure. Early in patients who present early, a simple dorsal gutter splint helps. Patients who present slightly late, a Kapner splint helps. In very late presentation, surgery followed by a Kapner splint is the treatment of choice. Beware that recurrence is very common. You must follow up the patient and ask them to wear the Kapner splint for a long duration, and beware of the problems of the Kapner splint. I thank you all for your attention.
Thank you. Thank you so much, sir. It was really a wonderful talk. I would just summarize all presentations in one liner. First talk given by Dr. Pankaj Ahire, we have to understand the anatomy of accessory collateral and proper collateral ligament and their attachment, which are important for biomechanics. Dr. Rohan Habu explained about first we have to see how we are getting the reduction with what degree of flexion, and then decide about splintage or dorsal block wiring. Main theme of my talk was if you have 30 to 70 degree of range of movement, then be very careful about having surgical intervention. Bipin explained if the joint is non-arthritic in a delayed presentation, then consider salvage. Prashant Kamble spoke about importance of wide awake local anesthesia with no tourniquet for central sleep repair and how it is important after repair. Then Dr. Patenkar sir explained in his pylon fracture about importance of distraction and about importance and role of bone grafting, which hardly people will ever think about having a bone grafting in acute scenario in hand fractures. Then Dr. Kiran Ladkar mentioned about how proper instrumentation is important. Like he mentioned about low torque drill to fix such a tiny fragment, to avoid splitting a fragment and to avoid another mishap from that fracture. Dr. Warrior sir explained about a very important concept of chamois approach. Probably if general orthopedic surgeons have not heard about it, please read about it. It is very important approach to avoid injury to the central sleeve, and that approach gives importance to exposure to condyle. And also he explained about soft tissue respect. Nikita Shetty explained about importance of intraoperative sonography, how important it is, and how do we assess joint intraoperatively before a decision making about fusion or salvage. Then Dr. Pankaj Ahire in his arthrodesis talk mentioned if there is a joint destruction and lateral instability, then only consider fusion. Otherwise, we should consider salvage. And the last talk was really a nice talk where Dr. Patankar sir explained about the importance of splintage and how careful we should use them. The patient has to be under your observation. And before making any splint or advising any splint, accurate diagnosis, like a soft tissue swelling on a X-ray, which is suggestive of a central sleep avulsion. So this was really a wonderful session for me also to learn. I hope all audience have enjoyed it. Over to Dr. Sandeep, Dr. Pradeep for the administrative remarks. I thank all the faculty for taking out time on a busy day, Friday evening, for this wonderful session. Thank you so much. Over to you, Dr. Sandeep.
Hi, Parag, Pradeep here. Thank you so
Pradeep,
much. Thank you so much, Parag, and the entire gantry of faculty for contributing. This is probably the first webinar for the WIROC, and it sets the ball rolling. I really thank all the faculties and the conveners for taking time out of their busy schedule. With your permission, I would like to end the meeting now.
Yes.
Thank you so much. Thank you so much.
Thank you.
Thank you.